Hey everyone, welcome to another surgical pathology basics video. Today we'll be covering benign anorectal disease. But before we get started, I wanted to think aloud a little bit about what the goal of these videos are, because obviously there's a lot of learning resources out there, some with different goals than others, and the reasoning behind what the videos are for should hopefully clarify some of the content. And so what I think I'm trying to do here, and obviously this evolves as I make more and more of these videos, is really distill what I think is the essential surgical knowledge for somebody either at a clinical medical student or an early resident level needs to deal with these diseases. And that's a little bit different than many other educational resources, which are maybe focused on shelves or really focused on being comprehensive. If you want, the details and the minutia, you can always go read Up to Date. But what these videos are for is for a very quick review of the most important high yield information that I actually use on a daily basis to deal with these diseases effectively in a hospital. And my hope is that getting that knowledge really helps you wrap your head around a disease, the fundamental pathology, the basic treatments. And then once you have that background, you can go fill in the gaps as you need it. But that you can really quickly go from a relatively low level of experience and knowledge and ability to function in the hospital to a much higher level quickly with these videos. But we don't claim to be completely comprehensive to be able to list, these 27-page long history and physical items that you find on Up to Date, things like that. So remember, this is not necessarily comprehensive, but we hope it is useful and clear. And you can always give us feedback and let us know if you think we are on the right track or not. So with that, let's go ahead and get started. So today, like I said, benign anorectal disease, and you can really only have two major complaints when it comes to anorectal pathology, and those complaints are either pain or bleeding, or, of course, both in certain diseases. So we've broken these lists down based on those two major categories of symptoms that the patient presents with, and we're going to go through these systematically. So within the pain category, the first disease we're going to talk about is anorectal abscess. Now, what is the underlying pathology of anorectal abscess? If you remember back to your pathology, we have these anorectal crypts. And once again, if you look at this, we're seeing a tube, right? And so you can imagine anytime we get a tube, that tube can get plugged. And then once you plug that tube, maybe a little piece of stool, whatever it might be, you can develop an infection behind it. And then that infection builds up pressure, gets bigger and bigger and bigger, and then it might progress and poke through into other places in the perirectal space, right? So you can imagine if we have these crypts around here, the most common site for an anorectal abscess is down here in this perianal location. But as these build up, they can then, through pressure, track to some of these other locations. And so when people present, they'll present frequently with exquisite pain. They have an acute infection in an area with a lot of nerves. They're typically in a lot of pain. And sometimes they're systemically ill. They'll have fever, etc. And so an understanding of these different abscesses really requires an understanding of the anorectal anatomy. And I struggled a lot with this as a medical student, so I wanted to take some time to go through this here. That's why I have this illustration. So your anus has two sphincters, your external sphincter, which I'm highlighting here, which is just kind of an extension of the levator sling muscles that extends down to the level of the anus. And then there's also the internal sphincter right here, which is really just a thickening of the wall of the anus or rectum, kind of that's contiguous along the whole GI tract. It's just slightly thicker in that area. And so most of our locations for anorectal abscesses are defined in relation to the sphincters or the levator muscles. So like I alluded to before, the most common and easiest to deal with abscess is the perianal abscess. So that's literally just down here in the perianal space. This example here, it could be here, it could be here. And I really just think of these as like butt pimples. They're just an infection. It's really superficial. You can see it. and it's easy to get to. So you can either take them to the OR and drain these, right? All infections need to be drained, or it can often be done just in the emergency room or the clinic. Just numb it up, open it up, and drain all that infection out. Another common area, the next most common, is ischiorectal, which this image has located up here. It can happen up there. Usually they're a little bit closer to the skin as well. And once again, if they're close, easy to access, we just drain those as well. Where it gets a little bit more complicated is when they're intersphincteric or intrasphincteric up here, or in what's called the supralevator space. If we have our levator muscles coming in here, you can imagine this is, the air, right? This is the skin. This is all area that I can easily access or cut into without cutting into muscle. And then the supralevator space is all the way up here above the levators, getting close to the intraperitoneal cavity. So obviously those areas are a little bit tougher to deal with. Sometimes they can be drained surgically through the rectum. Other times they're drained by IR. But the moral of the story that you need to know is that all abscesses need to be drained. Some of these are drained very easily because they're so close to the skin. Others are much harder to drain. And then generally, we'll give antibiotics for these pre-op, but once you've drained an infection in a healthy person, they usually do not need any antibiotics post-operatively. And then our next topic in the anorectal pain. Pain might not be the most accurate description of how these present. A lot of times it will be from discharge as well, but we're talking about anorectal fistulas. And so I put this right after anorectal abscess because they're very closely related. If you remember us talking about the pathophysiology of the abscess, we talked about obstructing that crypt, building up an infection, and that infection progressing to other spaces to cause infections in various locations. You can imagine if that tract stays in place, now all of a sudden we have a connection from our rectum or our anus to the external world, draining rectal contents, and you can get a fistula. This is actually very common after draining an anorectal abscess for a patient to develop a fistula. It happens about 50% of the time. So it's not actually it's important to tell your patients that because it's not a failure of the surgical treatment. It's just a very common and unfortunate complication. And these, again, are all named based on your anorectal anatomy, which I think is what can trip students up sometimes. So the easiest to deal with is the superficial abscess. This abscess will track somewhere in the anus here and stay completely outside this sphincter complex right here, and then exit to the external world somewhere. And then anytime we get the sphincter involved, we have more issues, right? So we could have an intersphincteric fistula tract that goes from the anus here, goes through your internal sphincter, and then makes its way out to the external world. I'll go ahead and clear this away, give us a little bit easier space to see. It can start in the anus, traverse both sphincters, and come out. That would be transsphincteric. And then some are either located in a very high area or traverse up this way, and they actually bypass the sphincter complex altogether, but they do it on the superior aspect. And so those are called supra or extra sphincteric fistulas. When we're talking about treating fistulas, there's two main ways to treat them. And it's essentially based on either damage control or definitive management. And basically those two ways are called setons or a fistulectomy or removal of the fistula. And a seton we use anytime there's sphincter involvement or a complex fistula because you don't want to cut through someone's sphincter. And that's really just, for example, let's say we have a fistula right here. That's literally just putting a almost rubber band like vessel loop through that to keep the tract open and allow any potential abscess in this cavity to drain out and prevent that from reforming into another anorectal abscess. And that actually lets the tract cool down, the inflammation cool down, and lets it heal down and it hopefully eventually go away once you remove that seton. The other treatment, like I said, a fistulectomy, I think is easiest to think about for these perianal fistulas. Once again, the most common and the easiest to deal with. You can see here there's no actual muscle or sphincter involved, so you can cut this out without any concern for the patient's continence. And that literally involves sticking essentially a little wire through this tract and then boving down onto it to fillet the fistula open and then letting it heal by secondary intention with that granulation tissue. Something to always think about with anorectal fistulas is you want to find both openings when you're treating them. And we'll talk about what's called Goodsall's rule a lot when we're looking for a fistula tract. And so if you imagine the patient's in high lithotomy here, so this is posterior, this is anterior, this is the anal canal, you could have fistula tracts that exit. We usually bisect this into anterior and posterior. So you can have fistula tracts that exit anteriorly up here or posteriorly. And depending on whether it's anterior or posterior, that helps you hunt for the internal tract that you need to find in surgery. And so the Goodsall's rule just states that an anterior fistula usually travels in a straight line right from the location of the external os to the internal one, whereas the posterior fistulas tend to travel in this looping line and go to the midline posteriorly. So if you're looking around in here for the internal drainage point of the perianal fistula or the anorectal fistula, if it's posterior, you're looking in the midline. If it's anterior, you're looking just at this radial direction from that external fistula tract. And one thing to think about with any anorectal disease, whether that's abscess, fistula, fissures, or things we're going to be talking about later, is you really always want to have Crohn's disease on your mind. So that's a question you'd want to be asking any patient. Crohn's patients do not get treated normally for these issues. Certainly you drain abscesses, certainly you drain fistulas, but you want to do as little intervention as possible because they have a very hard time healing that area unless they're on very good medical management. So that's something to always keep in mind for your physical exam as well, or sorry, your history and physical as well. All right, so our next pathology is the anorectal fissure. This one causes a lot of pain, but it also causes quite a bit of bleeding. So crosses both of our boundaries here. Usually pain is the primary issue for the patient. And so like a lot of anorectal pathology, this one is a little bit of a mystery how it comes about. Once again, if I draw this kind of looking from below, this is posterior, this is anterior, this is a stylized anorectal sphincter going around the anal canal. And either there's a trauma that causes a tear or there's just chronic ischemia from an overly tight sphincter. But whatever happens there, you get a tear in the mucosa. And when you have that tear, like we've mentioned before, it's a highly sensitive area, and you get spasm of this internal sphincter and it clenches down. And the problem with that is it clenches down so tightly that it impairs the blood flow to the area of that fissure and actually prevents healing. So the body's natural response to pain actually then causes issues with healing later. So all of our treatments for this focus on calming the sphincter down, relaxing the sphincter, and then allowing normal blood flow and normal healing to occur. And most of the time, this isn't even surgical treatments. You can do things like give patients fiber, make it less painful for them to have bowel movements, which will hopefully let things heal up. You can also use topical or systemic or really muscle relaxants or vasodilators such as diltiazem or nitroglycerin to place onto the sphincter and cause that relaxation. A little bit more invasive option then is injecting actually the paralytic Botox, which kind of does a temporary sphincterotomy or cutting of the sphincter, making that internal sphincter relax and allowing for healing. And then finally, the surgical option is what's called a lateral internal sphincterotomy. And what that means is you go in on the lateral aspect of the internal sphincter and you actually cut the sphincter. And that cut sphincter then causes relaxation and the time it takes for the muscle to heal back in and for the sphincter to work completely normally again. Hopefully the offending fissure has healed. And usually, since we have both the internal and external sphincter, that does not cause issues with continence, although obviously that's something you'd want to know about the patient beforehand. And if they do have incontinence issues, maybe a lateral internal sphincterotomy is not the ideal treatment for them. Once again, watch out for Crohn's. Really what you want to think about here is there are typical and atypical locations for anorectal fissures. Once again, if this is anterior and this is posterior, the most common, the vast majority, are in the posterior midline. Some are in the anterior midline. But if you have a fissure anywhere else, that's very abnormal. Then you should be thinking about Crohn's disease, HIV, maybe carcinoma. But you should not just go down the normal treatment pathway if you see one of these atypical fissures. And I believe this is our last pain-related pathology is external hemorrhoids. And so just talk about this briefly here. I think most people have a pretty good concept of what hemorrhoids are. They're shown in these two areas on this image. This would be internal hemorrhoids above the dentate line. This would be external hemorrhoids. Remember, these are just normal venous plexuses that for some reason, once again, not completely known, maybe the connective tissue weakens up here or the vessels become congested for whatever reason, but they become large, potentially inflamed. The internal ones can prolapse, the external ones can clot off and cause a lot of pain. But for whatever reason, these normal venous cushions become pathologic and cause some issues. So with external hemorrhoids, those ones down here, what usually happens is they acutely clot off and swell, and this causes really acute pain. And so if they have an issue with acute pain, that's usually a surgical problem. You can either go in and just lance and remove the clot or remove the entire hemorrhoid. The only thing to think about here, once again, drawing my stylized anal canal, there's usually 3 columns of hemorrhoids. You have your right anterior, your right posterior, and your left lateral. And so if somebody has issues with multiple hemorrhoids at once, you usually don't want to cut out more than 2 of these at a time because you would risk narrowing the anal canal with the scarring. We'll talk about internal hemorrhoids a little bit later, but for now, I just want you to remember external hemorrhoids, there really is not a non-surgical treatment for those the way there is for internal hemorrhoids. So usually we're talking about a hemorrhoidectomy. All right, moving on to bleeding. This is really the main isolated cause of bleeding without pain in the anorectal disease category. And so when we're talking about internal hemorrhoids, once again, same basic anatomy as the external hemorrhoids, but these are above the dentate line. This makes them insensate, so you won't feel pain from these sorts of hemorrhoids, but you frequently can have bleeding complications. These hemorrhoids are the ones that can be graded if you've heard about that before. So there might be grade 1, grade 2, grade 3, or grade 4 hemorrhoids. Grade 1 hemorrhoids are just like this, they just exist. Grade 2 will prolapse out, but then prolapse back in spontaneously. Grade 3, deleted all of those. Grade 3 will prolapse out and require manual pressure to be manually reduced. And then grade 4 is actually prolapsed so profoundly that they cannot be reduced even manually. So if you hear those terms, that's what they mean. Once again, you don't want to be fooled by more serious causes of disease. So for one, anytime somebody has significant anorectal bleeding, you want to think about more proximal causes of that bleeding. So a lot of these patients will need a colonoscopy to rule that out, unless on physical exam it's just so very obvious that they're bleeding from an internal hemorrhoid that's right in front of you. And then the other thing to worry about is taking a good history and making sure they do not have liver failure. And the reason for that is that liver failure can lead to varices, anorectal varices, and the treatment for these is not surgery because you would cut these out and then they would bleed again because you would still have that high pressure from that portal hypertension. And so the treatment for somebody with liver failure who has what appears to be internal hemorrhoids, you should not think of those as hemorrhoids. You should think of those as anorectal varices, and the treatment for those would be a TIPS procedure or some other procedure to reduce their portal hypertension. So when we're talking about treatment, once again, you can do a surgical treatment or a hemorrhoidectomy of symptomatic internal hemorrhoids. But what's nice about these is because of their position, once again, proximal to the dentate line. These can just be banded, and that can be done without any anesthesia at all, so you could spare the patient a trip to the OR. This can be done in clinic. It should not cause any pain as long as you stay above the dentate line. That's usually done. So if you can imagine the hemorrhoid sticking out, something like this, literally there's a device that kind of sucks it in and puts a band around the inside, and that band just cuts off blood flow to that tissue and it falls off maybe 5 to 7 days later. It's hopefully a painless process for the patient. All right, so that's all I wanted to talk about today. This is just basic benign anorectal pathology. Hope it was useful. Let us know if you have any questions. And remember, these videos are not for diagnosis or treatment of any disease, but for educational purposes only. We will see you next time.